So I was asked to talk about hypercoagulable disorders, and I have no disclosures, and I have some slides borrowed for this talk. So I'm going to talk a little bit about hypercoagulability, first with respect to normal hemostasis and clotting times, and then the natural occurring anticoagulants and a specialized clotting time for these purposes. And then I'll talk about venous and arterial thromboembolism, inherited and acquired thrombophilia, which, as you'll hear, is not the way we refer to the acquired disorders, and what we know about them that's clinically meaningful, and whether to test or not to test. And then, if there's time, because I'm going to try not to run over, there are a couple of cases attached, but they're self-explanatory. Okay, so how is thrombosis regulated, and what are disorders that lead to thrombosis, and whether they are all considered hypercoagulability or not? This is a slide taken from the CDC website. These circles represent the relative prevalence of causes of death in the year 2021 in the United States. And the biggest one is heart and circulatory disorders, which includes myocardial infarction, stroke, and venous thromboembolism. So a little under 1 million episodes of VTE occur in the United States a year, of which about 100,000 were fatal. These two little cartoons are just meant to explain, and actually there's an error in this little cartoon here, which I should have corrected, that in arterial thrombosis, usually there is a disruption of the endothelial surface of the arteries or the arterioles, often from atherosclerotic disease and fracture or necrosis of atherosclerotic plaques, and then clotting initiated by platelets, and then the deposition of fibrin. And these occur in areas of high shear where flow is rapid. In contrast, venous clots tend to be more composed of coagulation factor reactions resulting in fibrin clots and the capture of red cells in the fibrin mesh. And these tend to be predisposed primarily by stasis. This is just to illustrate that there's actually a yearly or a seasonal variation. This is 1995 through 1998. This is the relative incidence of deep vein thrombosis in red and pulmonary embolism in blue. And you can see that they are highest around December of each year, and they're lowest around June of each year. And presumably that has to do with infection, hospitalization, injury. About 25%, this is a weird number, and it might be interesting someday to go back and look at where this number comes from, but it is estimated that 25% of all episodes of pulmonary embolism present as sudden death, which gives us a higher mortality than what we're used to considering for PE. So this is a triad. In the center is thrombosis, and these three elements were proposed and described by Rudolf Virchow, who did it in about 1860 something, so about 160, 170 years ago, 160 years ago. And they include vessel wall injury, the stasis of flow, and the hypercoagulability of either the person or the circumstance. And these are elements of those, each of these sections. So atherosclerosis and other vascular diseases, alterations in normal flow, and alterations in the ability of the blood either to clot or to prevent clotting. And this is a new addition to the triad. So I'm going to spend some little time talking about some of these and more time talking about these. And I mentioned in the beginning that thrombophilia is usually not paired with the word acquired. I think most people don't really pay attention to the distinction, and I don't think it's a very big deal. But I think if you go to a hematology meeting, in general, this refers to all increased tendency to clot, and the thrombophilia refers to inherited disorders of hypercoagulability. So the thrombophilias are, in general, considered to be inherited. So this is just another way to look at the inherited and the acquired risk factors for thrombosis, or the hypercoagulabilities. The first 5 here with the red asterisks, we're going to talk about. These are inherited, they're prevalent, and a fair amount is known about them. These 4, I'm not going to talk much about, partly because, for example, hyperhomocystinemia is really questionable as far as whether it is related as a cause rather than as a fellow traveler of increased thrombosis. MTHFR, which is the gene in which mutations can result in increase in homocysteine, is in and of itself not relevant at all. In cases where homocysteine is increased, it's moot whether or not MTHFR is mutated. And in cases where MTHFR is mutated, but homocysteine is normal, that's not associated with any kind of hypercoagulable state. Pi1 and factor VIII can be associated with increased rates of thrombosis, but they fluctuate, and the hazard ratio of Pi1 overexpression is not far from 1. So we don't usually test those at all. These 5 we do test when testing is appropriate, which is a question I'll get to toward the end. And these are just a kind of a summary of the acquired risk factors, and you're familiar, I know, with all of them. And so we're going to talk about these and then a couple from this list. In particular, I'll mention HIT because it's common and it has a pretty high hazard ratio for thrombosis once it is present. The antiphospholipid syndromes we'll talk about because they're relatively common and extremely important. And I'll have a slide about COVID and hypercoagulability as well, because I want to bring up the current standard of care for that. This, for maybe the first or maybe 3, 4, or 5 decades in the beginning, in the first half and toward the central quarter of the 20th century, this is what was understood as the mechanism of coagulation. And as this resulted from the kind of a sequence of events in which one hematologist would have a patient who bled too much, and a second hematologist would have another patient who bled too much, and it would turn out that their plasmas corrected the defects in the other. And after a number of these were identified, then the molecules, the responsible molecules were identified, and then the sequence of events was worked out. But it was always known that this isn't the whole truth, always. There are elements here which don't explain some things that do happen and which imply certain things that don't happen as actually happening. This is an illustration of kind of a simpler version of how clotting, coagulation, and by the way, another terminology, coagulation has to do with normal clotting, and thrombosis has to do with pathologic clotting. So, and again, those aren't strict rules, but those are the ways in which you'll hear those terms used, for example, in a hematology meeting. Anyway, this is not as ridiculous as it looks, but it only becomes not ridiculous if we go through it one step at a time, and that we're not going to do today. But I will tell you that this little thing over here that says TFPI is a molecule that was discovered in around 1990 or so, and that led to this whole understanding. And this understanding actually does fit the facts. So the reason I put that up is to tell you that we're going to look at this instead. And this is a kind of very simplified version. The clot at the end is fibrin in green. The pro-thrombin time is this. And the PTT is this. So everything but 7 is in the PTT. And the reason this has some relevance is that the phospholipid for the PTT is different than the phospholipid for the PT. And I'll get back to that in a while. So for the moment, that's all I'm going to say about that. And we'll start to talk about the thrombophilias. So the 3 earlier discovered thrombophilias are deficiencies in protein C and S, and a deficiency of antithrombin 3. And I'm kind of figure you know all this, so I won't spend too much time, but protein C, when it's activated, inhibits 8 and 5, and it kind of puts the brakes on, right? This is ready to clot. This will clot in a matter of a couple of tens of seconds and result in a fibrin clot. But if protein C is present, activated protein C, it's going to put the foot on the brakes at factor 8 and factor 5. So it's a naturally occurring anticoagulant. Protein C gets activated by protein S and by thrombomodulin, which is kind of complex with thrombin. And I'm going to go back one slide just to make a little comment, and you'll see that the name comes up regularly. Thrombin is like the conductor of this whole orchestra. Thrombin knows it all, does it all, and it's pretty amazing molecule for anybody who has a taste for clotting. Anyway, so thrombin is inhibited by antithrombin 3. Antithrombin 3 is also now simply called antithrombin. So protein C, activated protein C inhibits 5 and 8. It requires protein S to work. And so the deficiencies of these two molecules, or these two, mutations of these two genes, result in very, very similar phenotypes. Antithrombin 3 inhibits thrombin. And as you'll see over here, it also inhibits a bunch of the other serine proteases, 10, and they're all in their active state. So it inhibits 10A, 9A, 11A, but most importantly, it inhibits 2A and 10A. And when we administer some form of heparin, it increases the efficiency or the effectiveness of antithrombin in inhibiting coagulation by a 1,000-fold. And heparins work by potentiating antithrombin. They do not work separately from antithrombin. Okay, over here, a word about protein C and S. They're both vitamin K dependent. And so in somebody who becomes vitamin K deficient or takes warfarin, these levels can fall, and though a vitamin K deficiency or warfarin therapy are in general pro-hemorrhagic conditions or anti-thrombotic situations or conditions, sometimes the fall of protein C is the first thing that happens. And the reason is that protein C has a very short half-life. So if we stop making all our vitamin K dependent factors right this moment, the first levels that are going to go down to a critical level will be the ones with the shortest half-life. And protein C has a very short half-life. So warfarin can cause a hypercoagulable state because of the rapid fall in protein C. Finally, using the same drawing, factor V Leiden and pro-thrombin gene mutation, G20210A, these are inherited disorders that result in hypercoagulability. And I'm going to talk about all of these in a little more detail in a minute. The pro-thrombin gene the mutation results in increased production of pro-thrombin to a sufficient degree to cause a hypercoagulable state. And factor V Leiden is sort of like the receptor analog to protein C deficiency, meaning in this situation, there's enough normal protein C around, but factor V Leiden results in a mutation in factor V that prevents its binding. So in a person who has factor V Leiden, this protein, this naturally occurring anticoagulant, can't put the brakes on. And so this pathway tends to go down to the final fibrin clot without somebody putting on the brakes. So factor V Leiden is the most common of all of those five. It was discovered in Leiden in the Netherlands. Leiden is home to one of the oldest and most eminent, or so I understand, universities and medical schools in Europe. And I think this building is part of that university. And the picture is pretty because of the canal and the bridge and the flowers. And Rembrandt was born in Leiden. And that's a pretty big deal, I think. So we like Leiden. Factor V Leiden results, as I mentioned, in resistance of factor V to activated protein C, and that goes by a name, APC resistance. And it's the most common of the inherited thrombophilia, meaning 3 to 5% of the general population of European ancestry will have this mutation heterozygosly. And if a person is a heterozygote, they have a 4 to 5 times increased risk of venous thromboembolism, and possibly a slight increase in the risk of arterial thromboembolism as well. Homozygosity for factor V Leiden, or for that matter, double heterozygosity for factor V Leiden and the prothrombin gene, result in a greatly increased risk of thrombosis. So in general, factor V Leiden and the prothrombin gene, which I'll show you in a second, are considered to be mild thrombophilias. And the mutation in factor V that results in APC resistance has been identified as about 30,000 years old. So the hypothesis is that this may have given some amount of survival advantage to people walking out among the rocks and mountains and being attacked by animals, or trying to kill animals for food. The diagnosis requires a DNA test, and so in New York State, we are required to get written consent. The prothrombin gene mutation is, as I mentioned, causes an increase in prothrombin, which results in hypercoagulability. It's fairly prevalent among all individuals who present with venous thromboembolism. I should say that factor V Leiden is even more prevalent among those individuals because it's slightly more common and slightly more potent. So about 2 to 3% of the general population of European ancestry harbors this mutation, and the hazard ratio is a pretty modest 2 to 3 times increased risk over baseline. It's also a DNA test, so it also requires the patient to sign written consent in New York State. So protein C deficiency, the pictures down here are pictures of warfarin skin necrosis, warfarin-induced skin necrosis. And this is an illustration of what I just described, namely that if a person is given a therapy that depletes vitamin K-dependent factors, the first one to reach a critically low level may be protein C. And when that happens, thrombosis may ensue. The way warfarin works is to lower factor 2 and factor 10, which are also vitamin K dependent and which have longer half-lives and which have been demonstrated to be the mechanisms by which people on warfarin are protected against thromboembolism. So this is kind of not as common as what we just saw, but still 1 in 200 to 1 in 500 of the general population is pretty common. And in neonates, if they are homozygous, they may be born in a fatal complication at birth or prior to birth, including widespread disseminated thrombosis and necrosis of the skin. Heterozygotes are pretty common, as I mentioned, and they have about a 7-fold increased risk. And the way you measure this, the way you diagnose this, is to measure a factor activity level in the plasma. Now, because it's a functional test that may be affected by anticoagulants, you can measure the antigen, but often there's something of a discrepancy between the two. And sometimes the deficiency is functional and not quantitative, so the antigen and the activity will, by definition, be discrepant. In general, the preferred therapy is a DOAC rather than warfarin, although before there were DOACs, there was protein C deficiency, and they were treated with great care by warfarin, but with a lot of help from low molecular weight heparin. Same picture, much less common, but occurs because of protein S deficiency, because protein S is also vitamin K dependent. The protein S has a kind of complicated biology because it's carried by C4b binding protein, which is an acute and chronic phase reactant. And so things that raise the concentration of C4b binding protein in the blood will lower the proportion and the absolute amount of protein S that's circulating free. And it's the free circulating S, which is the functional protein S. It sort of has a moderate, along with protein C, has a moderate increased risk of thromboembolism compared to factor V Leiden and prothrombin gene mutation. And it's considered either to be also a mild thrombophilia or, an intermediate thrombophilia. And the things that were true of protein C deficiency in general are also true of protein S deficiency, but there's a couple of additions. Most importantly, pregnancy and estrogens, and the fact that I mentioned that it's bound by C4b binding protein. And pregnancy results in a fall in protein S, predictably, which means late in pregnancy, it may be difficult to determine if the pregnant patient is deficient in protein S because of inheritance, as well as pregnancy, or because of pregnancy alone. But generally, the level of protein S due to pregnancy alone is maybe 30-ish%, where normal is around 50 or 60 to 140. And protein S deficiency plus pregnancy tends to bring the protein S down into the teens and 20s. The way to clarify that is to do a DNA test for the protein S gene. Antithrombin is also about roughly 1 in 1,000 in the general population. It's a stronger thrombophilia, and the hazard ratio is somewhere like 16 to 20. The patients with antithrombin deficiency may be resistant to anticoagulation. And the reason is that the action of antithrombin to inhibit thrombin or factor 10A is potentiated by unfractionated heparin and by low molecular weight heparin. And to try to anticoagulate a patient with these agents, if there is insufficient antithrombin as a substrate, then this whole mechanism can fail. Now, this is pretty uncommon in antithrombin 3 deficiency, but it's not unheard of. And often a test question will say that somebody got heparin or low molecular weight heparin, and they continue to thrombose, or their APTT didn't get prolonged. And it may be that the answer that question is looking for is antithrombin deficiency. In real life, it's not that common, although it occurs, but it seems to be a lot more common on tests. This is an interesting illustration. I'm not going to go into it, but it helps explain a couple of things about heparin and low molecular weight heparin. And if you're ever interested in understanding why we don't measure a PTT in low molecular weight heparin, that little box can explain it. So this is a summary so far. Antithrombin 3 deficiency, protein C, protein S, factor V Leiden, the pro-thrombin gene, rough prevalence in the population, rough prevalence in patients with venous thromboembolism, and rough relative risk of a first episode compared with control. So, okay. When do you test for these? That's kind of a big deal, and that also appears on tests. And in general, the people who write the tests test for these conditions less often than I do. So I'm going to try to tell you what they say, but really you have to individualize. And the key here is the word unselected. It is not recommended that we test for unselected patients with the first episode of venous thromboembolism. Now, there are exceptions even to that, but the reason for that is that mortality and recurrence after you make the diagnosis of venous thromboembolism and after you treat them appropriately will not be different for the presence or between the presence or the absence of inherited thrombophilia. A lot of things will be different though. And so sometimes in selected patients, it is appropriate to test for them. So for example, if a patient is young, and you can choose your age, but I think the age they like to give is 45 or less. If a person has recurrent thromboembolism, if there's a family history, and by that usually is meant at least one first-degree relative, and especially if the first-degree relative was young when they had their blood clot, and especially if there are more than one first-degree relative with blood clots or more than one family members in addition to one or more first-degree relatives. And this is also used often in the management decisions of pregnant women who've never had a blood clot, but who have thrombophilia. So this is a big deal in this little list. And finally, clots in weird places. And by splanchnic is meant hepatic vein, portal vein, splenic vein, mesenteric vein thromboses, cerebral sinus vein thromboses. And in these cases, in addition to the workup that we're kind of spending most of the time talking about, we should check for myeloproliferative neoplasm or PNH, because for unclear reasons, these two families of disorders result not only in hypercoagulability, but in intra-abdominal or visceral and intracerebral venous thromboses much more often than other groups of disorders. Okay, now among the acquired disorders, and I'm going to kind of go fast here, the most important ones are the antiphospholipid antibodies, I would say, and we'll start with the lupus anticoagulant. Of the antiphospholipid antibodies, this is the only one of the most common APLs that is identified and measured on a clotting test, meaning anticardiolipin antibodies, beta-2 glycoprotein 1 antibodies, which are kind of the rest of the group of most important APLs, are measured by serology testing. And then the other antiphospholipid antibodies are less standardized. They are less well correlated with phenotype and with clinical outcome, and based, and as you'll see in a second, based on the most recent criteria for diagnosis, are not included. And I'll get to that again in a second. So basically, remember I mentioned the phospholipid reagent is different for the PTT than it is for the ProTime. And the lupus anticoagulant was first observed because somebody had a prolonged PTT and they didn't have a bleeding disorder and their factor levels were normal. Then it turned out they had a clotting disorder. And it turns out in those patients, they have antibodies against the phospholipid in the test tube. But the phospholipid in the test tube is not the same phospholipid as the one in the test tube when we do ProTime, two different test tubes. So a test was designed to make this diagnosis, and then a second test, not using the PTT, but using the Russell Viper venom time, was designed because the Russell Viper venom cleaves 10 directly. So all of this stuff up here is now out of the picture. It's moot. And so when somebody has a prolonged Russell Viper venom time, it's got to be something from 10 through fibrinogen. So that leaves only 4 things to look at, plus the phospholipid. And just as a final word on this test, the D for DRVVT means to dilute the phospholipid, because anytime you dilute any clotting factor or reagent in a test tube doesn't care. It's a reagent. Doesn't matter where it comes from. And if you dilute it, the clotting time will be longer, slower. But if you dilute the one reagent, in this case, the phospholipid, that is the target of an inhibitor, well, instead of being twice as long, it's going to be 4 times as long. And that will indicate to you that what you've just diluted is the target of the inhibitory molecule. Okay, so antiphospholipid syndrome is a syndrome that's been defined, and I'll go over the definition in a couple of seconds. It causes venous or arterial thrombosis. It causes pregnancy complications, including miscarriages, and it can cause thrombocytopenia. And in addition to these phenotypes, there must be identifiable and consistently identifiable antiphospholipid antibodies. And so according to the revised Sapporo criteria, the antibodies which will fulfill the diagnostic criteria are the lupus anticoagulant or anticardiolipin antibodies, IgG or IgM, or anti-beta-2 glycoprotein 1, IgG or IgM, at a titer of minimum of 40 units and measured and positive twice, at least 12 weeks apart. And this magical number 12 comes from the fact that most antibodies circulate in our body between about 2 and 12 weeks. So by 12 weeks, if there's still detectable antiphospholipid antibodies, those are new. Those weren't there 12 weeks ago. And that shows us that this is a process rather than a molecule that's still floating around in our blood. There you go. And in addition to the antibody part of the diagnosis, it requires at least one thromboembolic event or at least one late pregnancy loss, or at least 3 early miscarriages, early meaning 10 weeks or less. This is meant to be an exclusive or exclusionary diagnosis. That means that if somebody fulfills these criteria and makes the diagnosis of antiphospholipid syndrome, they unquestionably have the syndrome, rather than trying to compose an inclusionary or inclusive diagnosis that will let some people into the diagnosis club without actually having the syndrome. Okay, the mechanism for thrombosis and antiphospholipid syndromes, first of all, there are probably multiple mechanisms. They are not completely understood, but there's some amount of understanding. And it may have to do with the antibody that we test for, or it may be that the antibody we test for is a fellow traveler of whatever those mechanisms are. And I won't go into that more in detail. The APLS can exist all by itself, or in the context of other autoimmune diseases, malignancy, liver, HIV, and so on. Typically, the lupus anticoagulant causes a prolongation of the PTT. So the reverse is a little bit more important, probably for you in your practices, but also when you're taking a test. If you have somebody with a prolonged PTT, you are going to want to demonstrate 2 things. Number one, that it doesn't correct with mixing, meaning there's an inhibitor in that test tube. And number 2, that when you then you try to correct it with a different phospholipid, like for example, platelets. Because remember, in our body, this inhibition doesn't occur. In our body, something else is supplying the phospholipid. And what it is in our body is the activated platelet. The platelet is activated, some of the phospholipids in the membrane flip, so that now negatively charged phospholipids are exposed and clotting occurs on that surface. So if you put in platelets or activated platelets into this test tube instead of the normal phospholipid reagent, that will correct it. And that's kind of the confirmation reaction to demonstrate that a person has a lupus anticoagulant. Okay, antiphospholipid antibodies are pretty strongly hypercoagulable, especially the lupus anticoagulant. It's less clear the overall risk for anticardiolipin and beta-2 glycoprotein 1 antibodies, but they certainly do combine with LA in a more than arithmetic increase in risk. And the famous triple positives, which is not very common, but triple positives have a very high risk of thromboembolism, venous and arterial and recurrent and refractory and fatal. Okay, a couple of other acquired hypercoagulable states, which we see often: malignancy, which is sometimes extremely hypercoagulable. It is felt that DOACs, and the ones that have been tested, I think, were adoxaban and primarily, although it's sort of thought by extension that any DOAC is reasonable in thromboembolism or hypercoagulability of malignancy. In pregnancy, we don't use DOACs, so women will get low molecular weight heparin for the duration of pregnancy and breastfeeding. And depending on the indication for treatment, they may or may not get treated or stop treatment at 6 weeks postpartum. And in some cases, sort of again, we try to individualize at 12 weeks postpartum. But what this means is that the hypercoagulable state of pregnancy doesn't go away when the baby is born. In fact, it sort of peaks very soon after the baby is born and then falls. Immobilization, obesity, I think there's some kind of uncertainty about how many hours counts on a plane ride. And by the way, remember, it doesn't have to be a plane. It has to be something where you're sitting and you don't get up. But it could be a car or a train or a bus. And estrogen-containing birth control pills. And there are 2 hormonal-based contraceptions which seem not to increase thromboembolic risk, and they are low-dose progestin by mouth and IUDs, progestin-secreting IUDs, whereas injected and depot implanted, even low-dose progestin contraception seems to be associated with a slight increase in thromboembolism. So if somebody either is or is believed to be hypercoagulable and does not want a non-hormonal contraception, we recommend either oral low-dose progestin or an IUD that secretes low-dose progestin. Okie doke. Some of the thrombophilias can occur in acquired state. Antithrombin can go out in the urine in nephrotic syndrome. It's made in the liver, and liver disease can result in a deficiency. I mentioned C4b binding protein in pregnancy as causes of protein S deficiency. The hypercoagulability in myeloproliferative neoplasms and in PNH are not completely understood, but there is a fair amount of understanding. And these, as I mentioned, often result in thromboembolism in splanchnic or cerebral veins and can result in arterial thromboembolism as well. HIT, we're going to speak about in a minute. I mentioned antiphospholipid syndromes. I'll show you a slide or two about COVID. Oh, and the COVID vaccination, which is very rare in the setting in which it occurs at all, which is AstraZeneca and maybe one reported case of Johnson & Johnson. It behaves a lot like HIT, but doesn't require heparin. Okay, so to think of a thrombophilia is to think about a thromboembolism in a young person, unprovoked, which I described the definition of provocation, maybe a family history, recurrence. I'm going to skip the rest of this because I don't want to keep you late. There is some evidence that ischemic stroke, especially in young people, may be associated with the inherited thrombophilias, although the conventional wisdom is that the inherited thrombophilias are associated with venous thromboembolism and not arterial thromboembolism. That's probably not exactly correct, but it's probably a matter of differential degree, where it is the inherited thrombophilias are much more associated with venous thromboembolism, but there is some evidence to suggest that there's an increased risk of arterial thromboembolism as well. This summarizes some of the evidence for stroke. This just summarizes in a qualitative slide the findings in peripheral arterial disease. We don't do much about homocystinemia. If you suspect hyperhomocysteinuria, which I think we almost never see in adult medicine, then it would be worth investigating this thoroughly. But and having a high homocysteine, we always try to give folic acid, B12 and B6 as to whether it results in a decrease in risk of thromboembolism. There seems to be evidence that says that's not the case, but we can sometimes lower the homocysteine. Okay, that's why this is important, this provoked, unprovoked business, because data collected over a couple of decades, 20, 30 years ago, up through the present, have kind of confirmed that if a person has an unprovoked DVT or PE, and they take anticoagulation for a finite period of time, and then they stop, they have a risk of recurrence of a significant risk at about 10 or more % for the first year, and then 5 or more % per year after that. In contrast to the risk of bleeding, either on a DOAC of about 1.1% per year and warfarin of maybe 1.5% per year. So the guideline is based, and the guideline is indefinite anticoagulation for unprovoked VTE because the risk of clotting is greater than the risk of bleeding. For a provoked VTE, and the provocations are the ones that I mentioned, the risk of recurrence after anticoagulation is stopped is less than 3% per year. So in the setting of a provoked VTE, in general, and this doesn't seem to make much difference after the first clot, whether or not a person has an identifiable inherited thrombophilia. This is not true of antiphospholipid syndrome. Antiphospholipid syndrome is an indication in general, with some exceptions, but in general for indefinite anticoagulation. But for a provoked VTE, the guideline is 3 months. And the 3 months business is based on a series of studies that showed that, but this was with heparins and warfarin, 3 months is, 6 weeks is inferior, there's more recurrence, and 6 months and 12 months and 2 years are not superior to 3 months with respect to recurrence prevention. Anyway, this is Thurner Syndrome. You can see that, as you already know, the vena cava is to the right of the aorta, and in the pelvis, the aorta splits into the right and left common iliac arteries, and the right common iliac artery overlies the left common iliac vein. And a cross section at this level shows that this is spine, one of the lumbar vertebra. And the arteries, first of all, they are on top of the vein, and second of all, they're muscular, and the veins are thin-walled and have low flow. So the right common iliac artery presses and flattens the left common iliac vein. This is Thurner syndrome. It's common. It's a cause of usually left leg DVT. And the treatment is not only anticoagulation, but almost always thrombolysis and or thrombectomy. Anticoagulation, the duration is a little uncertain, but maybe less uncertain when a stent is placed, which is pretty standard care now. And then anticoagulation for 3 to 6 months with the stent. And then following anticoagulation, aspirin, usually 6 to 12 months, but that's also not based on much evidence. At the time now, 3:51. Okay, I'm going to stop. The rest of this is COVID, which you guys know probably better than I do. This is the guideline about COVID from the NIH, which you may know better than I do, but it's here for you. I'm going to give you the PowerPoint so you can look at any of the slides you might want to look at. This is HIT, which you all know. And this is the argatroban protocol in the Mount Sinai West intranet, in case you don't know this by heart, which I have to say I don't know it by heart. And then there's a couple of cases, and that's it. So thank you. I hope you get to have a break. And if you have questions, I'll be glad to try to answer them. I see there's one thing in chat. You're welcome. Thank you for saying that.
Thank you so much, Dr. Cytryn.
It's always a pleasure. You know, I think next time, I was always told you should leave, I think it's 2 minutes per slide. That was before the days of PowerPoint. I think that's a good thing. So next time I'll try to prepare a 30-minute talk so that if you get stuck 10 minutes after the previous talk, you'll still end in time. Okay. Call me or email if you have questions, or ask them now if you feel like it.
Yeah, if anyone has any questions, you can post them in the chat. You can also unmute yourselves.
Okie doke.